Warm welcome to Matt Kaeberlein. Matt, great to have you with us.
Thank you. It's great to be here.
Yeah. Well, lots of questions on my mind. And we have one that we're going to go back to because you sort of gave a bit of point of view there on aging clocks. But let's just start with, what's your definition of longevity?
Yeah, I think actually that's a really important, it's also a tough question in some ways. But I think it's important because among the community of people who now sort of identify themselves as being in the longevity field, there are a bunch of different definitions. And I suspect in this room we've probably got 10 or 12. So the way I think about longevity, I'm a scientist by training. I spent 20 plus years in basic research studying the biology of aging. So that's the lens that I first see longevity through. I am now out of academia, so I've actually left my position at the University of Washington. I'm CEO of a healthcare technology company that runs clinical programs. So now I'm much more in the world of what can we do today to have the largest impact on people's health for as many people as possible. So I've started to think about longevity through a different lens. Certainly the biology of aging is part of that, but if I'm being honest with myself, in our clinical programs, it's maybe 50% of health optimization or health span. And that's only if you include lifestyle factors under the biology of aging. And I do, because there's a reason why exercise and sleep and diet and human relationships impact all of the age-related diseases. It's because they impact the biology of aging. But my point is also, there's a lot outside of that goes into longevity. And then as we've sort of heard in other conversations today, there's this movement by the wellness field who are now, many of them calling themselves longevity. There are a bunch of functional medicine doctors who now brand themselves as longevity docs. I'm not saying that's a bad thing, but the umbrella for longevity has expanded. And I think that creates a lot of tension, a lot of misunderstanding, some miscommunication, and a lot of opportunities. So that was a long answer, but I think it's a complicated question, actually more complicated than it seems on the surface.
And it's quite interesting that we're in a field, such an exciting field, where the whole sort of labeling of the field is a point of definition. I don't think there are many that have sort of...
And a lot of self-labeling, right?
Yeah. But just to keep on that topic, so lifespan, health span, or joy span? What would you choose?
I actually think all of that falls under health span, in the sense that obviously nobody wants extended lifespan without health span. I very much believe it's sort of a myth that's even a thing. Or maybe I should reframe that. If you slow the biology of aging, you will improve both lifespan and health span. I think you could make an argument that our current healthcare system has really been the only example of increasing lifespan without increasing health span. But that's because we didn't target the biology of aging. And I would say if you're healthy, you've got to have joy. One does not go without the other. But I do agree with the concept that we don't spend enough time thinking about joy, meaning, happiness, at least among scientists, we don't. And we probably should spend more time thinking about that, because there's no point in living a long time if you're not happy.
No, and it's really actually the essence of why we're here. But and speaking of that, we talked in a prior panel about aging clocks. Yeah. And your interpretation is that no, they don't fill the function and inaccurate at the moment. Just sort of out of your perspective.
I mean, it's a hard topic to give a credible answer to without some nuance and spending some time on it, but I'll do my best. So first of all, it's important for everyone in this room to understand, if you think that biological aging clocks measure biological aging, they don't. Just get that out of your head. They don't measure biological aging. They are all correlated to something that is correlated with biological aging. So usually mortality risk, or risk of an age-related disease, or sometimes chronological age. All of those things are correlated with biological age. They are not biological age. So that's point number one. I just think it's important to understand. In the research world, and obviously there are multiple flavors of biological aging clocks. So now I'm going to narrow this to epigenetic aging clocks. That's another important thing to understand. You can estimate biological age using a whole bunch of different parameters. Epigenetics is only one form, but it's the one that has been most popularized. So epigenetic aging clocks are really useful tools in the research world. And I think they will become useful in the clinical realm once we understand when they're being applied, how precise are they, how accurate are they, and at some point, can we make meaningful recommendations about care based on what they're telling us? That doesn't exist today. So I did a personal test. I took, and now I'm going to move to the direct-to-consumer space, because all of the tests that you see in these clinics, they're direct-to-consumer tests. They are not clinically validated. And that's important. In the direct-to-consumer space, there's no regulation. We don't know anything about accuracy. We don't know anything about precision. I did a personal test. I bought 8 kits from 4 different companies. The variance was a standard deviation of 7, and one company, 2 replicates on the same sample, 20 years apart. Okay, that's not useful in the clinical setting. So again, what it comes down to me is, and I said this, but I'm going to say it again, because I've yet to hear. I've heard people give sort of hand-wavy, answers, but I've yet to hear anybody really disagree. So if you disagree, I'd love to have you tell me. I don't think a doctor should ever use a test or a diagnostic that they don't understand how it works, that they don't know the accuracy or the precision, and that doesn't meaningfully inform care. Full stop. I just would love somebody to explain to me why, as a doctor, you would use these things. And I've heard the response that, well, we don't have anything better. Come on. We have dozens of biomarkers that are better predictors of health than an epigenetic age test, right? Glucose, insulin, lipids, inflammatory markers, toxins, body composition, how much weight you can lift, what's your VO2 max, what's your heart rate variability. All of those are better than an epigenetic test. So I just don't understand the rationale for using these things in clinical practice right now.
And I mean, taking a lens both out of a consumer perspective and also, of course, out of a scientific perspective, there might be sort of 2 facets to this, because I totally relate to what you're saying, but I think what one, Elizabeth or someone mentioned in the panel, that maybe to get a bit more advocacy for people wanting to understand sort of the pathways to longevity, and a bit maybe flattering ourselves when we get, the pheno or Grim test and it says 20 years younger, you're like, oh, okay, I'm on the right path. And I know that's not a scientific, but is there a correlation there that somehow one can?
So, I mean, I think you can definitely make that argument. I think one of the challenges is there's no guarantee you're going to get the flattering answer, right? Again, if it's just random, and maybe it's better than random, we don't know what these companies are doing. Maybe they're rigging it in their favor, so you get a score you like.
You mean like that?
But there's no guarantee. So this is the challenge. And to me, again, this is obviously just my opinion, that feels like an ends justifies the means attitude, right? Like if the goal is we're going to deceive people because it's going to help get them excited about the field, but I have a problem with that.
Okay, maybe not deceiving. Okay, does anyone have any questions about biological clocks that you want to address to Matt while we're on the topic? How many have tried them? Would you try them again? Did they give you some purpose, some insights? Oh. Okay, Matt's right. Oh, Julian, they gave you insights. Really?
Yeah, around information.
Information.
Specifically information.
Yeah, on certain maybe genetic. Yeah. Okay.
I guess the question I would have is how do you know you can trust that information based on what I just laid out and what we know, if it comes from a direct-to-consumer company?
I can't, but I did overhear a conversation you were having at lunchtime about wearables, and it's like, what is the purpose of these tests and wearables? Because if it is actually just to make the consumer feel a bit better about themselves, then it's possibly worth the £150, $200 that you spend.
Sure. Yeah, and I mean, I think that if that's true. So when you say purpose, you mean it motivates you, and I think that's a valid one. Like I've heard plenty of people say that the biological age test is a motivational factor that might get you to eat better or focus on lifestyle, and I think that works for some people. I think for other people it goes the other direction, and it actually can be a disincentivizing. So at the individual level, sure, that's great. And that's sort of my view. Like if you want to use these tests for entertainment purposes or it gives you something valuable, great, do it. I think as scientists and medical professionals, we should be telling people the truth and not misrepresenting what these tests actually are, and recognize that for some people it can have the opposite effect. And I put continuous glucose monitoring and other wearables in the same category, except we know the precision and accuracy of those devices, and we know mechanistically what they're telling us and why it's important for health. So,
yes, Jamie.
I want to follow Follow this thread just with a conversation that we had that I think is a nuance that actually deserves discussion, is that would love to have your take and discussion with the audience on the use of some of these unvalidated tests for clinical decision making. So I think that this is the next nuance, is actually using these within a setting that might either change or start an intervention or be used as proof that an intervention is working. So
I guess the first thought I would have is when you say, I think validated can mean different things to different people. So if we're going to put the high bar of FDA cleared or FDA approved, that's a clear line, but it's also a high standard. So when you're talking about tests that haven't been validated, I guess I would need to know what the specific test is you're thinking of, like example.
I would love, we've had this conversation, your take
Yeah.
on clinical decision making as a result of having an epigenetic clock.
Yeah. Well, again, it's easy because we don't know the precision and accuracy. So even if we knew the precision and accuracy, then I think it becomes a different question. In the absence of knowing precision or accuracy, it's foolish to make a clinical recommendation or decision on a measurement. This is where I think we can get to where should we be. It is a solvable problem to know the precision, at least, of these tests. Accuracy is harder. So again, in case anybody isn't familiar with exactly what those words mean, accuracy is how close you get to the true value. Precision is how close repeated measurements are to each other. Okay, we don't actually know the accuracy if you're going to use this as a biological age test because it doesn't measure biological age. But we can make an assumption about the accuracy that it can predict health or mortality. If we knew that, then we could use these tests longitudinally, meaning repeated measures over time, to tell whether someone's regimen is going in the right direction. That's how docs are trying to use these now. Again, you can't do that if you don't know the precision and accuracy. But in theory, that's how these things could be used in a useful way. And I'll say there's a whole set of diagnostics that could fall into this realm of they haven't been proven that they are effective at preventative healthcare. They're used in clinics in certain ways, but they haven't been proven that they're useful for preventative healthcare. And I think it's a case-by-case basis. And there, I think, as long as you know what the intervention or the test is doing and how effective or accurate it is, then it becomes the doctor and the client together. I think what Brad said makes a lot of sense to me. It's a conversation with the client or the patient, fully informed to make the best decision for that person.
Yeah, we have one more question.
So I think we need to make a distinction between somebody who is sick and has a disease and what you recommend as a clinician to deal with that. And I think we need to separate it when say we're talking about a healthy individual who has certain disease risks and whether we can mitigate those risks. And I wouldn't like any doctor making any kind of decision based on my epigenetics because I also believe that the science is not there yet. But also, a microbiome is not a diagnostic tool. It's not a validated diagnostic tool. Metabolites are not, that you can see correlation, but they're not really diagnostic tools, except for a few approved biomarkers, and the same goes for proteomics. But if you see the same thing popping up, you see the same disease risk coming up in someone's microbiome. You see not one metabolite, but a whole pathway altered, and their epigenetics. You look at the raw data of the epigenetics, and they all correlate in the same direction. You can still give a recommendation on a lifestyle choice on probably how to change those, even if it's not a clinical recommendation. But you may be able to reverse a disease that the person may have a high risk for, and it's a use of a number of different, and then you can correlate that with their labs. So it's just as a single data point, I totally agree with you. But if you measure a bunch of things together and they show a correlation, I think that's a little bit different.
Sure. So I mean, I appreciate that what you said, and there's two things I would say. One, I agree with you, and two, when I get this kind of a response a lot, and I always can't help but wonder, did I not explain this correctly? If it's done in a setting where you know the quality of the measurement, and we can have some confidence about that in the research world when it's peer-reviewed or in clinical studies that are peer-reviewed, I agree with you. You can make these pattern matches and correlations and recognize it's probabilistic, but probably pretty good. We don't have that information for the epigenetic tests. It's all opaque. These companies tell you nothing. The only way I know how bad they are is because I bought the kits myself and did the experiment. The same thing is going to be true for proteomics, metabolomics, transcriptomics, unless you collaborate with an academic investigator and you get access to the raw data. And again, you might be different. I don't know your background. I can tell you the vast majority of doctors that I work with don't dive into the raw data and do these correlation analyses themselves. So I agree with you in principle, and I would love to have clinically validated tests or measurements, estimates that can do that. We're not getting that right now, and this is a different conversation, but it also has come up today. You know, there's a rush to market in the direct-to-consumer space, which is counterproductive for doing good science and good medicine, in my opinion. But people can make a lot of money doing it.
Anyone else have any more questions? I'm going to look if you sent any. I'm just going to check quickly if we have any. But in the meantime, the dog aging project, which has really stirred imagination. So what can sort of doing a lot of research on dogs prolong or help, you know, the human health span?
Yeah, so I mean, I think probably everyone in this room recognizes the main point, which is that dogs age biologically faster than people do, right? This idea of 1 human year is 7 dog years, just another way of saying dogs age biologically faster than we do. And we have lots of ways to convince ourselves scientifically that that's largely true. So that means we can study aging in dogs faster than we can study aging in people. But companion dogs, so pet dogs, unlike laboratory animals, also share our environment, which is the other big factor that influences longevity, that in laboratory studies, we basically try to take completely out of the equation, right? We want to do everything we can to control the environment. So for that reason, I think companion dogs are a really powerful bridge to human longevity, both for understanding and intervening. And for me personally, I'm a dog person. When I started the dog aging project, I don't know, 12 years ago now, honestly, it was because I wanted to make my dog live longer. Like Daniel Promislo and Kate Creevy, who are the other co-founders with me, had been thinking about dogs as a model to study aging for longer than that. And in conversations with them, you know, I had this light bulb moment where I was like, oh my God, we know, I don't know, 5, 10 things that can slow aging in mice, make mice live longer. Some of those are going to work in dogs. Holy crap, I could make my dog live longer. And so then I had to do it, right? So I think that is the other part here, which is that for many of us, our dogs are family members.
Yeah, definitely.
And so there's an intrinsic value. We're going to learn a lot about human aging from studying aging in companion dogs, for sure. But there's intrinsic value, in my view, in being able to help people's family members, companion animals, live longer, healthier lives. So for all of those reasons, I think it's a very powerful, intriguing place to put my energy, because I think it can have a large impact. And it's really the first opportunity. So again, this concept has come up a few times at this conference, that nobody's going to do a lifespan study in people. We can't do a lifespan clinical trial. There are other ways we can test geroscience interventions, but in dogs you can. And it take you 3 years if you have enough resources. This is low-hanging fruit in my view, which is part of the reason why, if you're going to get me all worked up, I'm frustrated that more resources haven't been put in this direction. But you know, this is a no-brainer. Like, if we wanted to, 10 years from now, there's no doubt in my mind, if we put the resources towards it, we could increase healthy lifespan in dogs by 25, 30%. Like, this is solvable, guys. So why haven't we done it?
I ask you the question, why do you think it hasn't been done then?
I mean, well, part of it is getting people to believe, right?
Yeah.
And again, when we started the dog aging project 10 years ago, I don't think the longevity movement, for lack of a better way of saying it, had the energy that it has today. I think most people, even back then, still didn't recognize that aging is modifiable. Most people still don't in the general public, but everybody in this room probably does. So that group of people has gotten bigger. I think nobody's done it. I mean, let's face it, most people are pattern matchers. They're going to invest in what's been successful before. So the first time you try to do something different, it's really hard. And it took us 6 years to get the first NIH grant to do this, even though everybody I talked to is like, yeah, that's brilliant, but you'll never get anybody to fund it, right? So sometimes big ideas just take a long time to get funded. And it's been rocky. We lost our NIH funding for a period of time. Yeah, in the middle of a clinical trial, if you can believe that. So again, I don't want to go down that path. But on the bright side, there are now companies. So I think we help create a template for innovators, entrepreneurs, to recognize there is a market opportunity here to make a lot of money and do some good stuff in the world. So it's happening. It's just happening much slower than I think it should happen. But I think people are starting to recognize the opportunities here.
And probably in these kind of environments where you can share and talk more about it and where people are more knowledgeable, maybe that can spur even more investment opportunities. Yeah. Anyone else has a question in the meantime? So going from biological aging clocks to dog aging projects to rapamycin. There are two sides of the same coin. Some say, yes, it's working, or increasing muscle mass. We heard from Brad, we heard from Tobias this morning that it's not really, increasing.
Sure.
What's your take?
I guess I would say my view on rapamycin hasn't really changed in the last 3 to 5 years, other than to say that there's been more anecdotal data pointing in the right direction for human health in certain contexts. Mm-hmm. So the fundamental question is, we don't know today whether rapamycin slows biological aging in humans. We don't know whether or for who rapamycin would be likely to increase health span and or lifespan. There are a lot of reasons why we don't know, but we also do know it is the most robust and reproducible small molecule to have those effects in laboratory animals. We're doing the experiment in dogs. It'll be a few more years before we know the answer there, and I'll be able to tell you about lifespan in dogs. So all I can say is I've probably collected the most data from people using rapamycin off-label of anyone, and I'm cautiously optimistic. I can say confidently, I am personally convinced there are a subset of people who get great improvements in quality of life when they start taking rapamycin off-label. I don't know if they're aging more slowly. I don't know if they're going to live longer, but they have significant improvements in how they feel and how they function. Those are largely people who have high levels of chronic inflammation, often following a viral infection. Okay. I can tell you others. For those of you who are interested, I've got a podcast. I'm going to shamelessly plug it. It's called the OptiSpan Podcast. Talk a lot about rapamycin, talk a lot about other stuff. Check it out. But I go into a lot of detail on where I think rapamycin has good evidence, where it may not. But it's not a miracle pill. I mean, I think we should all just accept that.
And we don't have one yet, but...
Yeah, rapamycin isn't.
Yeah.
At best, it's going to significantly increase health span and maybe modestly improve lifespan for a subset of humans.
Well, some people, just to dive in, because GLP-1s has been really a topic as well, and some say with Ozempic, you lose weight, but you don't build muscle, and then you have rapamycin, could the combination of both, a bit of microdosing of both, be a
So a couple things to say there. I'm really bullish on GLP-1s too. I'm intrigued by the possibility that they may impact biology of aging independent of appetite suppression. So again, calorie restriction, laboratory animals, best way to slow aging in laboratory animals. Probably slows biological aging in people, probably won't help you live longer, healthier life because of detrimental effects that'll offset the benefits. GLP-1 agonists are going to have that effect in a subset of people, but there's intriguing evidence they may impact the biology of aging independent of appetite suppression. That's interesting, far from demonstrated. And then you brought up the combinatorial. I mean, I don't know about rapamycin plus a GLP. I'm in the process of working with a colleague of mine at the University of Washington, Jonathan Ahn, to get a clinical trial going to test that. Specifically, rapamycin plus GLP-1 agonist with individual drug arms. So hopefully we can start to answer that question. But I think this question of combinatorials is really important. Yeah. And we have almost no information on interactions for biology of aging, for longevity. And then I think it was Matt Cooper who brought up the negative interactions. We have to be concerned about that as well. There are strategies to actually do very, very large-scale combinatorial testing for longevity. This is, okay, I'm going to shamelessly plug another interest of mine that I have yet to actually get off the ground, which is I feel like the field has narrowed prematurely, and I'm a fan of the hallmarks of aging, but I think it's a consequence of the hallmarks of aging, and that when the hallmarks became the dominant paradigm, everybody laser beam focused on the hallmarks. And the question is, how much of aging do the hallmarks of aging represent? I would suggest it's a tiny, tiny fraction of biological aging. I don't know the answer, but I liken it to, I don't know if you guys have seen the map of the Earth in 500 BC. It's called Hecates's map. Look it up. It looks nothing like what the actual map of the Earth looks like. It's like a oversized Libya, a sort of weird-looking Europe thing, and then Asia, and then you sail too far and you fall off the edge of the planet, right? I think that's kind of the level we understand biological aging today. That's not a bad thing. Hecates's map was really useful in 500 BC. People got rich. They traded, they explored, they warred, right? It was really useful. Our understanding of the biological aging today is really useful. We can do important things with it. But if we don't start thinking about what we don't know, what happens when you sail off the edge of the biological aging map, we're never going to actually get to the point that I think some people in this room want to get to, which is better than rapamycin. And sorry, I know I'm going on a tangent, but I think these are messages that people need to hear. Everybody thinks AI is going to solve aging. It's not going to solve aging until we give it the right data set. It's going to be garbage in, garbage out. So I think we need to have some emphasis on discovery science, and that's not happening right now. So my shameless plug is we developed technology when I was at the University of Washington to solve this problem. We can do 1 million intervention tests for lifespan, I don't know, $5 million. I know, I'm being cut off. If anybody really wants to move the needle on new discovery in the field, I'd love to talk to you. We can do this. I think it's important. And I'll say that's not the only way to do this. There are other approaches that can and should be taken to learn what we don't know.
Yeah, and we understand music-wise. And I think that's a really good conclusion, too, because it opens up for collaboration, it opens up for incentives, and it opens up the dialogue, which is what we need to actually propel this forward. So, Matt, thank you for opening up that, and thank you for all the work that you do. Thank you.